Hello, my name is Dr. Michelle Talukter, and this is my QI project titled Adverse Events, A Resident's Role in Reporting, done with Dr. Mary Najjar, Dr. Leja, Dr. Aurora, and Dr. Faruqi as our statistician. Adverse event analysis reporting is necessary in the pediatric hospital system and is utilized to report errors and near misses. Pediatric residents are often present to witness adverse events or are involved in them. Residents may not report for various reasons, including but not limited to the following: knowing where to report them, not knowing if it is an adverse event, unsure of the effect of reporting the event, not having the time to do so, or not even feeling comfortable to do so. Our objective was to create an educational and safe environment to facilitate discussions regarding specific adverse event analyses. The aim of this project is to make residents understand how to report an adverse event, when to report an adverse event, and increase comfort in regarding adverse event analyses. 32 second and third year residents at Children's Hospital of Michigan participated in adverse event analysis case presentations from September of 2023 to April of 2024. Third year residents were divided into groups of 3 and 4 and required to present a case in which an adverse event has occurred. Each presentation consisted of 40-minute case presentations, followed by an attending-led discussion of the adverse event with a group of PGY 1, 2, and 3 residents. 2 one-hour lectures were provided to the residents on how to conduct an adverse event analysis by the director of the QI of the Pediatric Emergency Department. A pre-survey was provided prior to starting these cases and a post-survey midway through these case presentations. The survey consists of 12 questions utilizing the Likert scale to assess confidence and comfort. The Wilcox signed rank test was used to compare the results of the pre and post test of the residents. As you can see in the results section, the median in the pre-test was 22, whereas in the post-test was 25, showing a significant p-value of less than 0.0001. Likewise, you can see the minimum and maximum in the pre and post-test has also increased accordingly. Some of the questions highlighted in the bottom dive us into the exact specifics of confidence. In one of the questions, how confident do you feel to be able to identify an adverse event in your clinical work? As you can see in the pre-test, residents felt 12% very confident, while in the post-test, 27.9% said they felt very confident. In another question, how confident do you feel to be able to propose a possible intervention to address an adverse event, error, or systems failure? You can see there's only a marginal amount that felt confident, very confident in the pre-test, while in the post-survey, 18.6% felt very confident. In our last question that's highlighted, how confident do you feel to identify factors that contribute to medical errors or adverse events? 8% felt very confident in the pre-survey, while 23.3% felt very confident in the post-survey. As you can see, residents do worry about receiving poor treatment from colleagues or hospital staff when speaking out about an adverse event or error. They also feel confident about identifying factors contributing to errors or adverse events in their ability to use a fishbone diagram to identify a problem. And lastly, there was an increased confidence in the ability to propose an intervention to address an adverse event, error, or systems failure. However, no differences were seen in the residents' confidence in being able to identify adverse events, the likelihood of using our system for reporting errors, or finding value in spending time going through different adverse events in our hospital system. In conclusion, reporting adverse event analyses are essential in a hospital setting. Resident education is necessary to appropriately report adverse events, and their comfortability to do so is imperative. Limitations in this QI project include the choice to exclude PGY1 residents as they were not familiar with the reporting system at the institution at the time of the pre-survey. Additionally, there is a potential for difference in responses on the pre-survey due to previous experiences that residents have had. And lastly, for the discussion, only hospitals attending and pediatric emergency attending were present. These attendings were not directly involved in the case, therefore case presentations were solely based on the resident group's experience and interpretation. Thank you.